Good evening, faculty members. Sorry for the delay. Shall I start now, ma'am?
Yeah.
Yeah.
Shall I start now,
Please
sir?
start.
Patient Mr. Loganathan, a 52-year-old male residing in Chennai, is a lorry driver, has come to our hospital with the chief complaint of wound over right knee for the past 1 month. He was apparently normal 3 years ago when he sustained a self-fall from his lorry and injured his knee. He was diagnosed with a closed comminuted patellar fracture. Was He was admitted and underwent open reduction and fixation using KYS, and tension band wiring was done. Patella. Over period, patient was uneventful and the patient returned to his normal regular activities. Patient had a pre-op X-ray is post intervention, the tension band wiring. So patient had a foreign body sensation where he could feel the wire in his operated site, but for which he was reassured by his doctor. 6 months later, patient had complaints of exposed implant and a minimal serous discharge, which was initially managed conservatively. He had a similar episode 1 month after 1 month ago. This is the second episode, and which the increased severity. So this time, patient developed a swelling of the right knee, which was initially insidious in onset, progressive in nature, initially not associated fever. Patient developed a multiple discharging sinus from the surgical site with the pus discharge. Surrounding skin discoloration was also noted. Patient did not give any history of a restriction of knee movement or a difficulty in ambulation. Patient noticed a progressive increase in the skin discoloration and the frequency and amount of discharge. So he underwent wound debridement 2 weeks ago, and the implant exit was done by the ortho team. Now, patient has come with the complaints of raw area with the right knee. At present, patient does not have any complaints of fever, no history of any discharge from the raw area, no history of any skin changes around the raw area now. So the past history, no history of any cardiac or illness due to diabetes mellitus, systemic hypertension or TB. No history of any other surgery other than the trauma for which it was managed. Personal history is a known consumer of alcohol, smokes cigarette, and is a mixed diet. Continue with the examination.
Yes.
General examination. Patient was conscious. He was well oriented time, sir. Well oriented time, place, and person. Is moderately built and nourished. No signs of pallor, cyanosis, ichthus club, generalized lymphadenopathy, no signs of epithelial edema. Vitals are normal. Systemic examination, CVS RS per abdomen normal. Local examination, inspection, and ulcer seen over anterior aspect of knee, right knee.
You are not audible.
Can't hear anything.
Yes, ma'am. I think the connection is not up to mark. I think their Wi-Fi connection. That's what I think.
Maybe they should just come on the mobiles only.
Yes, I think so.
Just as curious, share the presentation in another phone while we talk in this phone, man. Don't know some technical issues. Just a minute.
Yeah, just come on the phone.
Presentation.
You are keeping your presentation as your background. That's why we can't see your video, one thing. And second thing is Wi-Fi connection is highly unstable, I think.
Recording in progress.
Sai Karthik.
Hello. Can you see our video?
If this happens, we are going to get a resound. So at least mute that, mute or reduce the volume of your mobile completely. You can't play two devices side by side, then we are going to have something like voice disturbance or resounding is going to happen.
And can you see our video, ma'am? Our faces?
Video is clear. Your audio also clear. Your faces are not seen. Please go ahead.
Okay, ma'am. Sorry. Local examination, inspection. The attitude is hip in extension and minimal external rotation, knee in extension. No obvious apparent shortening of limb noted. An ulcer was seen over the anterior aspect of knee, which was irregular in shape. Thighs approximately 9 cm longitudinally, 5 cm horizontally. Margins are irregular, epithelialized. Floor has pale, unhealthy granulation tissue. Extent from superior border of patella to 4 cm above the tibial tuberosity in the midline. Extend medially in irregular fashion, measuring roughly 5 cm. Surrounding skin appears hyperpigmented. The right knee appears to be swollen compared to left knee. No obvious muscle wasting noted. Limping gait noted in the patient. No active discharge noted. The surrounding skin was not warm, not tender. Palpation, sorry. Inspectory findings confirmed. The ulcer base found resting over bone. Peripheral pulses were palpable. All sensations were noted to be intact. On active range of movement, flexion, the patient was able to flex from 0 to 110 degrees. Power normal. The passive range of movements were noted similar to the active range of movements. No limb length discrepancy noted. No muscle wasting noted. The picture of the ulcer shown.
There we can see the extent from the suprapatellar region and inferiorly 4 cm above the tibial tuberosity, and it extends in the medial aspect alone. And moving on to the diagnosis, it is a post-infective raw area, right knee, status post-op implant removal, that is a K-wire and the tension band wiring, and wound debridement. Can we proceed with the investigations, ma'am?
Yes,
I
I
have one
think.
question. I have one question before you go.
Yeah,
Was
please.
he
ma'am.
walking normally after the fixation initially until when the raw area appeared again?
According to the history told by the patient, because we didn't receive the patient before the raw area, ma'am, so we didn't see or examine the patient before. What he told us, he was able to walk. Now he is not able to walk because of the pain. That is what the history he is telling, ma'am. So the 3 years post-op, that is after the K-wire.
Can't hear you again.
Ma'am, am I audible now?
Yeah,
Yes.
you're audible.
Yeah, audible. Okay, Prakash. I have a question.
Yes,
Yes. First, you answered to Madam Smita's question, and later on, I have a question that is he normal between the first surgery and then second exploration of this K-wire?
Pardon, ma'am, I didn't catch your question, ma'am.
Is he normally walking?
No, ma'am,
following the first
actually,
surgery?
Ma'am, based on his history, he was normally walking, ma'am, but we saw the patient only after the second surgery, ma'am. We did not
What
see
is
him
the
before the first.
reason for removal and exploration of the wound?
The implant got infected, ma'am, and the implant removal was done by the ortho team. When he presented 1 month back to the operating doctor, that is the orthopedic surgeons, they had told him that the K-wire and the tension band wiring has got infected and it has to be removed. And it has gotten infected and the skin has also become necrotic. That is what the history been told by the patient. And hence he was operated for implant removal. And while doing implant removal, they found that the skin overlaying the implant was also non-viable. So they had debrided and created a raw area.
Okay. At present, the patella is it okay? Patella?
Yes, ma'am.
It's not
We have
exposed.
of X-ray as well, ma'am. I'll be showing that in the investigation slides.
Yes, it's all right. Okay, show the X-ray.
Can you just tell again the palpatory findings, please?
Sir, was ulcer noted in the anterior aspect of right knee. The surrounding skin appears mildly hyperpigmented, not warm, not tender. The base of the ulcer, had a pale unhealthy granulation tissue. The ulcer was found to be resting over the patella. No active discharge needed. It was of longitudinal length around 9 centimeter and the horizontal length was around 5 centimeters, sir. It was irregular shape and the margins were found to be epithelialized, sir. The patient did not have loss of sensations or any other complaints.
Yeah, continue.
For diagnosis will be a post-infective raw area.
And moving on to investigations, I would like to do routine blood investigations because patient was also had history of pus discharge, fever for a brief period to look for the total count, everything, and again wound swab to be taken for culture sensitivity, and then X-ray knee to look for the healing of the patella which had happened, and other investigation for routine anesthetic workup. And this is the X-ray of the patient before the implant removal. When he got admitted, here we can see the patella has reunited, though there is some amount of mal union, it has united. And can we proceed with the treatment plan, ma'am?
What was the swab culture sensitivity report of this patient?
Swab, when we took it, came as no growth, sir. But we didn't receive any. Apparently they told that it had pus culture, pus pouring out from the sir. But that report we didn't see, sir. Because patient didn't have any reports. Patient came with just a raw area to us. He was discharged from the orthopedic ward, and he came to us with this ulcer, sir.
Okay.
So on our investigation, when we took swab, it turned out to be no growth as of now.
Considering the area in which the raw area is, what should be your aim in treating this? What should be the aim when you're choosing your cover for this?
Stable, thin, pliable skin cover.
It should not hamper any movements also because it is over a joint. So stability as well as it should be pliable.
Okay. It should not have any mechanical obstruction, extending and flexion. And how will you plan the flap or whatever you do, whatever your plan is, in what position?
To assume, I will first see how much of debridement is required, depth that is seeing the wound. Since there is no active discharge right now and the X-ray doesn't show active features of infection of the underlying bone, I think I can get away with around 0.5 to 1 centimeter of clearance given and thorough scraping of the wound margin. After now the ulcer is around 9 centimeter, 9 cross 5 centimeter. So post debridement, I expect the wound size to be 10 cross 6 centimeter. So I will use that to decide my flap cover, ideal skin or cover for the patient.
Okay, proceed.
So the first plan would be a proximally based sural artery flap for this patient. As mentioned earlier, since there is no active discharge from the wound as of now, this will fasciocutaneous flap will be ideal for my patient. So this is the marking of the proximally based sural artery flap.
I have a quick question before we go for the flap.
Yes, sir.
Since you know this is a bone involved infection, would you expect the bone infection to be completely resolved without doing any other further investigation?
Sir, since he did not have any hampering of his mobility, either before immediately after the procedure or even now, he has only a minimal limping gait. I'm assuming that it has not involved the knee joint. There is no involvement of the synovial lining or anything. So I think I can consider only doing a fasciocutaneous flap for this patient, sir.
Yeah, considering the duration of the problem, he had on and off couple of times and the implant was removed. All the more, did you get the implant culture done?
Actually, patient came later, sir. He was not immediately referred even after the debridement.
Fine. What
He
is
was
the gold standard of investigation for the bone infection, osteomyelitis?
Past culture sensitivity or
technetium-based bone scan, sir.
The gold standard to rule out absolutely no infection in the bone.
Synovial fluid culture, sir.
No, the reason I'm talking because he's a laborer, he is a driver, he has to use his knee joint for a long time. And there is even a speckle of infection can lead further issues if you cover with the bone, if the flap also. So if there is a long-term antibiotic given or not is one question. Second thing, we need to understand, is there an active infection in the bone? Though bone looks fine, but is there any gold standard investigation to say there is absolutely no osteomyelitis and he doesn't need antibiotic and we can go ahead with the coverage. Coverage is anytime is required, definitely. But ruling out infection, if infection is there, what will be your first plan? If infection is not there, what is your plan? That is what is the question.
If infection is there, another round of debridement and pus culture sensitivity or wound culture sensitivity has to be sent, and appropriate antibiotics, preferably IV antibiotics for 14 days, has to be given for the patient. And look for repeat culture sensitivity and repeat X-rays to rule out infection. Then I will go ahead with the flap cover. And
Yeah.
if there is
So
signs
can
of
we,
active infection,
if there is infection is there and you wash it, you debride, can you do the coverage because it's a joint, major joint? So can you cover the joint with some other flap other than what you're doing now?
we can do a muscle flap, sir.
Yes, that
With
is the
increased
reason I'm
flap.
asking. That is the reason I'm asking. So can you get confirmation that bone infection is not there is the question. So what is the gold standard? I'm not going to answer this, but I want you to make a point on that. What is the gold standard of investigation for the rule out osteomyelitis in the bone? Yeah, I mean the infection culture. Okay.
Sir, a technetium-based bone scan, sir.
Technetium-based bone scan, will it give you the information what bacteria is there, what sort of culture sensitivity we can rule out? Is that
No,
can
sir.
answer that one? No.
No,
Yeah.
it cannot answer that.
Biopsy.
Fine. Yes, biopsy is the answer. Bone biopsy is the answer. Yeah. So I know it is some people would not agree on that, but bone biopsy will give you more information what sort of bacteria or organism is there, and accordingly you can treat for long term in such patients. Because the major joint, if again reinfects, then it will be an issue. So if infection is there, discharge is there, you wash it nicely and you can give a muscle cover. But yes, I want to understand more flap from your side now. Yeah, continue.
Our first plan for this patient would be a proximally based sural artery flap. The marking of the flap is based on the sural nerve, which is the axis of the flap. The median sural artery, which is around the flap, and the short saphenous vein forms the vascular axis of the flap, and that is the midline, which is the midpoint of the popliteal crease to the midpoint between the lateral malleolus and the tendo Achilles. A line is drawn, and centering this, I'll do planning in reverse so that I can and the pivot point will be the midpoint of the midpoint of the popliteal crease. And based on planning in reverse, I'll mark the flap. And here in this photo, we can see the planning in reverse has been done and the flap has been marked. And approximately the dotted lines denote the adipofacial flap. Approximately the minimal S-shaped curve denotes the incision, and it is completed as an island flap. And once the flap is raised in the proximal part, it is raised as adipofacial component, and then the flap is tunneled in the medial side over the defect. And this will be the reach, and this is the video showing.
Okay, before you
We can see
proceed,
the flap is-
before you proceed, I want to ask one question. What is the size of the defect, did you say?
9 × 5 centimeters.
That is with the knee in extension.
Yes, ma'am. Yes, ma'am.
And your flap size also is the same.
No, ma'am. We have given allowance for knee flexion as well as for the wound debridement. The flap was 11 × 7 centimeters, ma'am.
That you have to mention, no?
Yes, ma'am.
Because once you flex the knee and you measure, and that is what you will need, the flap cover should on that defect, because in flexion only you will have the maximum length of the flap, length or width, and once you extend, it has to be pliable, it has to be flex at the knee.
Yes, ma'am.
Okay.
Have you
Go on.
have you counsel your patient that because the range of movement in the knee is 110 degree? You said something,
Yes, sir.
right? So have you counsel your patient before surgery that what kind of a range of movement he is going to get after surgery and all that? Because
Yes.
professionally he is driver.
I would like to counsel the patient that first, because it is a proximal base oral artery flap, the lateral part of the foot, there will be loss of sensation. And being an Indian, he might have sitting cross-legged at home as well. So I'll inform that to the patient as well and get the due consent as well. And then I'll inform the range of movements that it will be almost similar to this. And the full range of movements, like previous to the injury, might not be there. Though with aggressive physiotherapy, the range might come to near normal, but we cannot guarantee the full range of movements. But whatever range of movements he is having at present, that is 0 to 110 degree, will be preserved.
Right. So that is first primary thing before embarking the surgeries and all that, you know. So the counseling of the patient before surgery is very, very important in active limb. Okay, you can proceed now.
So that will be our first plan, sir.
Considering that he's a driver, and you're with the sural, you have the paresthesia, is that still your first choice?
We thought since it can be an islanded flap, which can be tunneled, and it's a fasciocutaneous flap, we thought that could give him good cover.
Around the knee joint, you know, there is plenty of anastomosis. There are a lot of other flaps that you can use without causing any problem for him, right? So why was this your first choice?
Since the defect is of bigger size, we will not consider a lot of perforator flaps, ma'am. Because since it is preferable for surgically created wounds and for smaller size. And since we wanted a thin, pliable skin flap, we thought this would be a better option.
All right, go ahead with your option 2 or whatever you want.
Our second plan would be medial gastrocnemius muscle flap with SSG.
So why you are ready with your second plan? Do you anticipate anything? You know, what is in your mind that you are ready with the second plan?
Supposing
some infection, as mentioned earlier, if there is any infection or
flap fails, then since we are already made a midline incision, it will be easier to do a gastrocnemius muscle flap. So that is the thing. This is the second plan in case the first plan fails rather than an alternative plan.
If you want to use a muzzle flap, what should be the reason for it? Is it because it will reduce the infection and the bone infection or
Contour
anything?
deformity.
Sorry?
Contour deformity or any cavity.
Yeah, that should be the only reason to use a muzzle flap because of late we all know that faciocutaneous or a muzzle flap there is no advantage of a muzzle flap over a faciocutaneous infection is concerned. It does not increase your vascularity or anything. Only if there is a cavity, you need to fill it with a muzzle flap.
We were concerned that the medial superficial artery perforate our skin component since we had already elevated the proximally based sural flap. This may be cutting close and it may also impinge that will not have the full flexibility. So that was one reason that the faciocutaneous flap from the skin or from the leg was not attempted, ma'am. And already since we had a scar in the leg, we did not want to jump immediately up to the thigh for the next, utilize the previous incision line to go for the muscle flap.
Okay, proceed.
And this will be the medial gastrocnemius muscle flap markings. In the midline incision, the previous incision can be utilized as well. And through the same incision, incision will be made up to the fascia. Sorry, will be that. The midline raphe between the medial and the lateral gastrocnemius can be identified. And through sharp dissection, initially muscle can be split, and then the muscle medial gastrocnemius can be hooked around using blunt dissection using fingers or any blunt dissection, and the muscle can be released medially as well up to the plantaris tendon, and then muscle is released distally as well up to the musculotendinous junction. So that tendinous part can be should be taken so that the insertion also becomes easier when we cover the wound. So once that is done, we will either inside in the middle part of the knee joint, or we can again tunnel it using the same tunnel which we have previously created, and then cover the defect, and then over the muscle we can give SSG. And this is the video showing the reach of the medial gastrocnemius muscle flap, which is also reaching our defect.
Have you marked the proposed debridement, the new wound after debridement on the? There is no marking on the wound.
We marked it in a lint paper, but not over the wounds.
Okay.
What would you do if the gastrocnemius is short?
If the gastrocnemius is short, the ways are either we can score and increase the length of the gastrocnemius, or go into the proximal popliteal region and erase some of the origin, so that the reach will be much better, ma'am.
You've
So
done
can you
that,
tell us?
it still doesn't reach. What you'll do?
Dissecting the fascia from the origin, scoring in the under surface, or taking as an islanded flap can also give a little more better reach.
Okay.
Can you tell us the origin of the gastrocnemius muscle?
Arises from the medial femoral condyle.
Okay.
The medial head, and the lateral head arises from the lateral condyle.
So if you to increase the reach, as madam is asking, can you detach it from the
erase
origin?
it from the origin, sir.
Right.
This
One
you're using the
question.
medial gastrocnemius.
Yes, ma'am.
Which is bigger, the lateral or the medial?
Medial, ma'am.
What
Yes,
are the
sir.
other flaps that you can do? What is the anastomosis around the knee joint?
There are numerous anastomosis around the knee joint between the superior and the inferior genicular arteries, superior and medial and lateral, superior medial to inferior medial and supralateral to inframedial. And along with other arteries to the profunda femoris also there are multiple anastomosis.
Okay, so you can do a lot of flaps around the knee joint because of this very rich vascular anastomosis.
Yes, ma'am. So based on any of those perforators also we can give a durable cover as a propeller or a perforator based flap.
No.
Can
Yeah,
you tell
from
us
my
about the
side,
perforator flap near the knee joint?
There is a saphenous artery perforator flap. Also, lateral genicular artery perforator flap is also available, sir.
And medial sural artery perforator flap is also there, the leg, from the leg if you want. And in the thigh, from the lateral genicular artery or medial genicular artery or posterior thigh flaps can be taken.
okay, Prakash, from my side, I
Yes,
have
ma'am.
a question.
Yes, ma'am.
So, till now you have explained these so many flaps, no?
Yes,
So
ma'am.
this gastrocnemius flap and then reverse proximally based reverse sural, and then most of the perforators are all around the knee joint.
Yes, ma'am.
So as the defect is looking is a 10 into 6 centimeters, and bone is also appears to be is a smaller one. Is a patella is also it's a little one is exposed. Okay.
Yes, ma'am. Yes, ma'am.
So the joint movements and then the flexibility is also adequate.
Yes, ma'am.
So in that situation, the which flap is the better for this defect among all these discussed?
And fasciocutaneous
You
flap
prefer.
will be
Yeah.
a fasciocutaneous flap will be best for patient.
Yes, yes. Instead of utilizing this muscular, this gastrocnemius, such a huge muscle,
Yes,
it's
ma'am.
better to have a fasciocutaneous flap is the vital one, that too pedicled one.
Yes, ma'am.
That's why
Yeah.
our first plan was proximally based sural artery flap, ma'am, which is a fasciocutaneous flap.
Is there any other way other than this proximally based reverse sural? The perforator based flap, is there any perforator based?
Yes, ma'am. Medial sural artery perforator flap can be taken, or lateral genicular artery perforator flaps can be taken.
Yeah. Is there any role of Doppler using that? Have you checked this Doppler?
Yes, ma'am. We checked, ma'am. Medial sural artery perforator flap we checked. We found the artery around 9 centimeters from the medial condyle of midpoint of popliteal to the medial malleolus, the line joining, and from around 9 centimeter we found the Doppler, and also at 15 centimeter we found the Doppler. So
Yeah.
that could be used. And lateral genicular also we found, ma'am.
Yes.
So since perforator flap, we thought that fasciocutaneous proximally based, and in our department we have done some cases, so we thought this will be a safer option since we have done this multiple times in our department.
Okay. What about the post-operative care of this proximally based reverse sural? The position of the patient on post-operative period, how do you keep the leg?
With knee in extension, using flexion preventing slab over the post aspect of knee for 14 days, 2 weeks, ma'am. Till suture removal, I'll keep, followed by partial weight bearing, and then as usual, adequately hydrating the patient and taking care of the flap, upper limb elevation, all those things, ma'am.
But okay. So is it okay after completion of this entire period of physiotherapy and all? What about the flap durability and all? Is it okay? You have adipofacial, no? Flap was islanded.
Yes, ma'am.
Is it okay? This pedicle base and axial vessels and everything okay survived?
Yes, ma'am. We have done 2-3 cases in our department, and we had good results, ma'am. We had
Okay.
tunneled the adipofacial part, and the skin part was islanded, which was used to cover the defect.
Okay, it's all right. Okay. Proceed.
And the third plan, should we proceed to the third plan or anything else, ma'am?
Yeah, you proceed.
A third plan could be any of the perforator flaps or a reverse ALT flap, which can be done.
Distally based.
Yes, ma'am.
Okay.
Yes, ma'am.
Yeah,
Yes, ma'am.
distally based pedicle ALT.
Yes, ma'am.
But as per that, the defect is not so problematic as it is subcutaneous and also looking
Yes, ma'am.
simple.
Yes, ma'am.
All these major procedures, from my side, I will not choose those flaps.
Yes, ma'am.
Have you,
It's a only propeller flap also sometimes. We can use this propeller flap.
Yes, ma'am. We can use a propeller flap
Yeah.
on the medial or lateral side, and based on the perforator, we can take a propeller flap for covering the defect.
so you have thought about the plan 3. Are you ready with the template or that? If you are ready with the template, you can show us the template.
Prepare for a perforator website. Yeah, we didn't make a template for this. We had only 2 slides.
Okay, no problem. So tell us about something about the anterolateral thigh flap. How will you do the reverse? What is the vascularity of reverse anterolateral thigh flap?
It is based on the descending branch of lateral circumflex femoral artery, and marking is done from the ASIS to the supralateral border of patella, and the midpoint is taken. And as 3 centimeter radius, we mark a circle which forms the majority of our perforators, and then we Doppler the perforator, and then that will be our perforator marking. And then, since it is a reverse anterolateral thigh flap, the pivot point will be roughly 4 to 10 centimeters from the supralateral border of patella. And then planning in reverse has to be done, keeping this 10 centimeter point as the pivot point. And then the flap should be marked after planning in reverse over the perforator marking. And then skin has to be islanded, and there will be a tail part of the flap as well. And then the flap has to be rotated 180 degree, or whichever side is coming minimal, less than 180 degree. And then we have to give inserts. Initially, the incision should be done in the medial side, and then we'll go subfacially. And then between the rectus femoris and the vastus lateralis, there will be a septum. And then in that septum, we'll find whether the perforators which we have marked pre-op are actually supplying the flap which we have marked. And then we'll find the source vessel proximally as well as distally. Proximally, first initially we will dissect, and then both proximally as well as distally. And then once the dissection is done and the source vessel is also identified, we'll clamp the source vessel and check for the viability of the flap. Because it's a reverse flow flap, we'll check for the viability of the flap. And then if it is viable, then we will suture ligate the proximal descending branch of lateral circumflex femoral artery, and then take the flap, elevate the flap, and then give insert over the knee region, sir.
So how will you check how will you prove your vascularity? You are applying something on the proximal part of the pedicle?
We'll use vascular clamps to clamp the descending branch of lateral circumflex femoral artery, so the source vessel from the proximal region.
So it is a problem, when you elevate the flap, when you apply your clamp, and then you will proceed for the flap. Otherwise, you will have to abandon your procedure.
Yes, sir. Yes, sir.
Right. And how will you rotate the flap? You said you will rotate. Sometimes it is a musculocutaneous perforator. It is not every time it is subcutaneous perforator. So
Yes,
if you turn on the clockwise, how will you check? How will you put it through the clockwise or anti-clockwise?
The rotation should not be more than 180 degrees, sir. So the whichever forms the least amount of rotation, I'll take that so for this case, I think right new clockwise, yes, sir, clockwise, sir.
Yeah. So the second question is, in a perforator flap, when they rotate the flap, what will you do for initial time? When you rotate the flap clockwise or anti-clockwise and then put it at the defect, what will you check for?
I'll check whether the flap is viable and there is slow sustained bleeding.
Sir, we have to see whether the pulsation is there
before
Okay.
before rotating, and whether that is the perforator is a good sizable perforator also.
Perfect. So, and then second, suppose you feel now when you rotated the flap, first thing you will see the vascularity, and second is venous congestion, because the perforator vena commitants are very sensitive. So what will you sprinkle on that perforator?
Lignocaines.
Perfect. Yes. Any panelists want to ask something?
Other than these three plans, are there any other plan where we can escape without doing much dissection, and can we just, since the defect is 11 by 7 centimeters in allowance, with allowance requirement? Yeah. Are there any other plans where we can cover it? See,
Propeller
this
flap from the thigh.
Lateral genicular artery perforator cluster.
Yeah. So can you do that planning, and if you have made any templates on that?
Sorry, sir, we didn't make a plan for that, sir.
It's fine. So what is the principle in propeller flap? What are the principles in propeller flap? What you would do? How do you geometrically
We have to
place
mark. We have to mark the perforator from the defect, and so there will be a from the perforator there is a proximal and the distal margin of the wounds. So till the distal end of the wound, it is considered as X. The flap should be marked on the opposite side, X plus 1 centimeter, giving for the allowance for the flap as well. And the intervening skin bridge between the proximal and the distal is also there. So that will rotate around to cover the donor area. So basically in a propeller flap, based on this perforator alone, the entire flap survives. So the flap has to be islanded on all sides, along with the periperforator dissection has to be done. So this periperforator dissection also helps in the vasodilatation of the perforators, so that the vascularity of the flap is also maintained. Sir.
Okay. What is that? What is the advantage in doing this flap over other flaps?
It can be closed primarily, sir, because it is 7 centimeter in the thigh.
Sir, for two plans, the first plan we are sacrificing a sural nerve. Now, second plan we are sacrificing a muscle. So if you're taking a propeller flap, we need not cause any much morbidity. It's donor side morbidity is less in a propeller flap.
Yeah, correct.
So why wasn't it your first choice? Yeah, that is what I asked you earlier. Why wasn't that your first choice?
And we were not actually we tried a lateral genicular. The lateral reach was a little bit extended. We need to make a bigger point, and the pivot point was a little bit doubtful. That's why that plan was not my first choice. When we saw the marking, it was that's why we didn't had that in my plan.
Okay. Well, which are the 3-4 main points you will see for when you are planning a perforator flap? Which are the 3 or 4 points, major important points in planning of that?
Yes, sir. Sorry, sir. So first I'll make a non-determinate incision so that to see whether the perforator is viable. What I have Dopplered, whether it is a good perforator, whether it will sustain the flap, it will hold the flap fully. And after dissecting it, whether the adequate caliber, whether it is pulsatile, also I will check it. And
the facial opening should also be adequate, so that it remains that it is a good perforator.
Good.
Yes.
And it should be accompanied by a vena committance as well.
Okay.
And then if there are multiple perforators, I'll again nearby, I'll like to clamp the other perforators and see if this perforator alone supplies our entire flap. And after ensuring that, I will proceed with the islanding the flap and then giving insets, sir.
Okay.
Fantastic.
And then would you like to see the length of the perforator? Because you have to turn the perforator flap. So what is the ideal length of the perforator you wish to have in your flap?
Asking about a caliber or length, sir?
No, length of it,
Length.
because you are turning it, you know.
Yes, sir.
Because you're going to mobilize the flap completely. So sir is want to know the perforator length so that there is no tension when you're rotating the flap or covering the defect.
No
At
kink.
least,
No
without,
kinking.
I'm not sure of the exact length, sir, but it should not have any kink or any tension. I'll just stay on table. So sorry, sir, not aware of any particular length, sir.
So if it is adequately more than 1 to 1.5 centimeter of length of your perforator, so you can adequately turn the flap without kinking or pressure on the perforator.
Okay, sir. Thank you, sir.
Any questions?
Yeah, we have spoke about regional, local regional, and sort of distant also. Yeah.
Right.
For completion's sake, can we plan some free flap? For completion's sake.
Sir, I had the chance to attend a recent talk by GK sir on reconstruction around the knee. So what sir was telling is free flap is a bit difficult in the knee because all the vessels are situated in the posterior aspect and the deep also, the popliteal fossa. So they are not our first choice, even if the defect is big. We'll always prefer regional flaps. But they can be done. It's not like they cannot be done, but they're a little bit difficult since they're in the posterior and the deep aspect. The vessels that need to join. The term that sir used was
I agree with it, but what I'm trying to tell is for completion's sake.
completion thing.
Is,
Then we
yeah.
can go for instead
If
of
it
this
is-
reverse
if
anterolateral
it is-
side.
If it is
Yes.
all of your donor areas are not, whatever is not there, then you are left with something else. Yeah. So
Right.
forget free flap. Are there any other flaps to cover the defect if the complete, this is a completion sake, okay?
Sir,
So-
are you thinking about a cross leg flap, sir? Cross?
No,
knee?
hypothetically, I'm just putting a situation.
Then
here.
straightforward, you can go for a free ALT flap, sir.
Or a skip flap also can be done, sir.
Where will you anastomosis in the case of free flap at knee region?
By Godina's approach, posterior aspect near the popliteal it has to be open, and then we have to give anastomosis in the posterior aspect only, sir. Though we can give insert with the perforators around the knee, but they might be very small. So for a safer approach, we can go and give anastomosis to the popliteal artery as well. End to side anastomosis.
You can very well open up the adductor canal and do the end to side anastomosis
Yes.
for the area near the knee, you know.
Yes.
Yeah, medial.
Kamal sir, any question? Madam?
No, sir. No, sir. I'm done, sir.
Okay. Okay, I think we are fine with the long case now. Sir, can we proceed for the second session?
Yes, sir. We can, sir.
We have 10 minutes more. If you want to discuss anything, if some bone defect is there or it is extending to the upper
Any question from the audience? This session can go on then further.
Okay, one question. Where you planned a gastrocnemius flap, so would you prefer a musculocutaneous, with the skin, musculocutaneous flap or just a muscle flap with skin graft?
Ma'am, if I'm taking a flap, the only thing I would wish to do is for a control infection or something.
No.
Only for
My
a reach
question
I
is-
wanted. Yes, sir.
No,
Yes,
my
ma'am.
question is whether just a muzzle flap or a musculocutaneous flap. Any
Ma'am, I
advantage over
prefer
that?
Do muscle flap only, ma'am, since it may cause contour defect in the lower limb. That will be aesthetically also will not look good. Since I have adequate reach with the muscle itself, I don't want cutaneous flaps.
But it can be done. But since this patient already we have a midline incision, which proximal base sural artery was our first plan, and since we are releasing.
No. I cannot accept that you're losing your sural artery flap. If your gastrocnemius is your first choice, then would you do a muscle flap with skin grafting or a musculocutaneous flap? That is the question. Forget about your midline incision with your sural artery flap and all that.
I will prefer musculocutaneous flap only, ma'am.
Yeah, why? What's the advantage over muscle and skin grafting?
Ma'am, I will avoid a contour defect in the leg, and also it will look aesthetically better for the patient if instead of a musculocutaneous flap. A muscle flap alone will look better, and reach is also we are able to reach.
So what is the vascular supply of the skin?
Skin will be based on the perforators arising from the medial sural artery.
No.
And beyond that muscle, it will be based on a random pattern supply, beyond the muscle.
No, the skin component of the flap is supplied by the perforator arising from the muscle belly and the facial network of the vessels. It doesn't come from the vessel directly for you. This provides a longer flap with more skin, and only the gastrocnemius muscle will not be sufficient to create the defect. And in the traditional design, both the muscle and the skin flap should move together in the same direction, and the perforator is coming from your muscle belly and the facial network of vessels, not directly from your vessel.
Yes.
If you read the Pontent article, the Pontent described the various flaps, and the super flap, Pontent super flap is described because it is given by dual supply, as Madam is saying. It is the musculocutaneous perforator as well as the perforators coming in the long axis of the flap. So that is why the extent of the Pontent super flap is much longer than other flaps.
1:3 ratio is.
Yes.
Who was the first one to have described the fasciocutaneous flaps?
Ponton in 1991 said that along with the fascia, if it is taken, then the suprafacial plexus also gives more supply, so that the length to breadth ratio can be 1:3, so that the reach is better.
Yeah, Pontin was the first one to describe that. Okay.
Any questions from the other team? If
that can be taken on later on. First, we will take some questions from the participants.
Okay.
Well, Dr. Prakash.
Ma'am, sir.
Can you hear?
Yes, sir.
So, regarding addressing the bone patella, is it an essential bone to be preserved after being fractured, got infected? Already you have discussed so much nicely. Can it not be removed and repaired the extensor expansion?
Sir,
so that you procedure after that?
Sir, patella has a unique role in that it provides a lever action. That amount of effort required by the quadriceps to extend the knee, it reduces the effort, sir. So since we don't have
a communicated fracture of the bone, then you have to remove it. If there is a communication of the fracture or an infected bone, I think that can be removed and you can go for a better reconstructive procedure.
No, already sir, but as of now, there is no infective changes or any osteomyelitic changes.
Can be done, sir, but
difficult to appreciate clinically to know infected bone, and it will not serve its functional purpose. So I think in this case, if you see the X-ray also from that, the bone is not a normal bone. So it can be removed and you can repair the extension expansion of the extensor or the quadriceps, and they go ahead with a reconstructive procedure already we have discussed. So that will be easier for you for the reconstruction. And you can take away the bone, means you are taking away the infection as well with it. I think that orthopedic surgeon and you have to make that decision finally. I just remarked for your observation. That's all.
Now, one of the questions in the chat box is, in proximal sural artery flap, what will be the orientation of the flap vis-a-vis the length and width of the defect?
Sir, we are not able to hear you properly, sir. Sorry, sir.
You can see in the chat box also, in proximal sural artery flap,
Chat
what will
box.
be your orientation of flap with respect to length and width of the defect?
So as we have shown in the flap marking and the link piece, it has to be oriented.
It is
more
same like a
vertically.
RSA. Instead of a distally based, it is proximally based. The same
Flap
flap marking.
So since the defect is oriented horizontally, I would like to orient the flap more vertically so that once it turns, the horizontal defect is covered.
What is the vascular basis of this
That is
flap?
the question is
Proximal
meaning, sir.
flap?
Proximally based sural artery.
What is the vascularity?
From the median sural artery, sir.
And what about the reverse sural?
It is the communication between the median sural and the perforate propeller from the peroneal artery perforators, sir.
Anything else in the reverse sural? Any other supply or?
So, what is the safe limit of infially based sural flap?
From lower two-third and upper one-third junction, sir. That is a safe limit. We can harvest a flap primarily, sir. So that will be the safe limit. And more than that, we have to do a delay, sir.
If you cross beyond that line, no?
Yes,
Delay?
Sir.
Okay.
Yes, sir.
What kind of a delay would you do? What are the types of delay that you know of? Now you made me ask you this question.
We can give parallel incisions, ma'am, over
There are specific names for the kinds of delay that you can do.
I'm asking the types of delay you know of.
Surgical delay, standard delay.
All right. Now you go and read that. And okay, you've done a delay. Now, when is the right time to raise the flap and why?
7 to 7 days is the ideal time, ma'am. 1 week. Beyond which, whatever we have cut will again the flap which we have islanded the flap for the neovascularization to happen. So based on that, beyond 7 days, it will again revascularize from the adjoining areas. So 7 days will be ideal. Will be ideal.
There is a specific thing that happens during the delay. And
Opening
the
up
time,
of choke vessels, ma'am.
Yeah, the choke vessels. That's what the choke vessels. So choke vessels open up at what day, and they generally close by what day. So between that range of days, you're supposed to raise the flap. Otherwise, there is no meaning in doing a delay at all. Right?
Yes, ma'am.
So what are the ideal days? What time do your choke vessels open, and when does it kind of close back?
5 to 10 days.
5 days, around 5 days it opens up, ma'am. Beyond the 10 days, it starts closing up. 7 to 10 days, we have to finish our flap
insert.
Fair enough. 7 to 10 days, you can raise it to 12 days. All right. So you need to go back and read about the types of delay.
Yes.
And then you also need to learn that if you don't know something, don't use that word. The examiner will catch you on that. Okay.
Now the patient says, I don't want any flaps. Can you help me without doing any flaps?
Sir, in this case, I will do a negative pressure wound therapy for 1 week and apply SSG, sir. That will be the simplest for the patient if he doesn't want any flaps.
You said there is a bone exposed.
Yeah, that's why I wanted to do a negative pressure wound therapy, sir, to increase the granulation to cover the bone.
Okay, how long does it take to cover the 1 centimeter of bone with the negative?
since this patient is having only a very small area where the bone is visible, so I think with the 1 week or 5 to 7 days, it should cover. But if it's not adequate, then probably I can drill it, patella small bone.
Arun sir was saying take the
Skin
patella
substitutes
only
like
now.
IDRT or BTM can be used.
And matridum.
Matridum.
Yeah.
What
are
is
the new-
superior? What is superior? The I mean, negative pressure wound therapy or putting some dermal matrix, dermal implant?
If the patient is affordable, dermal matrix is better, sir.
Why?
We are creating a neodermis. We are giving a new dermal layer, so that will be the contracture, everything, all aspects, it will be better.
Yeah, because you want to have a full range of movement. Whatever
Full
the
range of
movement
movement.
range of movement is there, you want to maintain that range of movement. And that when you apply the dermal implant, the soft and suppleness of that particular healed wound is far better than putting graft directly on the granulation.
So
So what
this
would what would your preference be for a dermal mattress?
Ma'am,
And why?
matridum, they are marketing it as same time when you place, you can harvest the SSD and apply. But
what
colleagues
is the what is
No,
the
no,
what
no,
is
not
the no no no
not
no
not
what
all the not all the matriderms. Only the
exactly
1 mm matriderm you can put a graft immediately. But
yeah
otherwise, you will have to wait. If you put the regular matriderm, you'll have to wait until there's granulation, the dermis is formed, and then only you can graft. And the
to
same
me
way with the Integra also, no? There's the Integra without your silicone layer, where you can straight away put a graft, or with
No, we
the
have to wait
regular
for 3 weeks
Integra
and
before, you have to wait for 3 weeks, and after that only put a graft.
which is better, Integra or matridum? Hello.
we haven't used matridum, sir. We have only used Integra in our
we have used, sir, but we have not used that much to know which is better, sir.
Okay, so matridum you get in variable sizes, right? 1 mm, 2 mm, and so on. How about the Integra? Do you get in sizes?
it's a 5x5, 10
No, I
cross.
mean to say
No, thickness. He's
Thickness,
asking about
thickness.
thickness, regarding about thickness.
Yeah. So which is better? Matridum is better or Integra is better? Biocompatibility wise and infection control wise, which is better?
I don't know, sir. I'm sorry, sir.
Yeah. So that is one. But if the sir was asking very specifically that if the patient needs that the skin is very pliable and we need extension allowance movement. So which is better now? Matridum, Integra. And there is a bone exposed also. Which is better again?
Sorry,
So,
sir, we are not
so both the companies are fighting against each other now. So you take a decision who is better and what gives more advantage over Matridum and Integra and utilize. Yes, the patient without flap, if they want to ask all these things, then you have variable options. That is what I just for the completion sake, I'm just putting this across. But these are not my first choices, but yes. But I'm just giving you the discussion can go from basic flaps to the modern required available resources. Yeah.
Kamal sir, thank you for bringing that point. It's a nice point to discuss now. The junior people have to learn about these things, newer dressing materials and all that.
Thank you, sir.
Okay, Prakash,
Ma'am,
from my side.
yes, ma'am.
One for me. In case of reverse ALT,
Ma'am.
the post-operative complications. If you chosen this reverse ALT for this
Ma'am.
defect, what could be the post-operative complications you may observe?
Since it's a reverse flow flap, we can see venous congestion may be seen. So we need to be vigilant to once we see that we have to try to correct it by using adequate fluid elevation. And
Then
other than that, regular flap care only, ma'am. I don't think that anything extra is.
yep, okay. If you found that it's in a venous congestion, so what are
Yes,
the
ma'am.
steps do you want to take to avoid the venous congestion? What are the steps do you prefer?
Adequate fluid intake for the patient.
First, I'll remove the sutures and then adequate hydration, around 5 to 6 pints of fluid per day, and adequate limb ventilation.
Yeah,
But
limb
after if I find that there is a severe venous congestion, then I would return the flap, make it like as a delay, then again attempt it 2-3 days later to see if flap has settled, ma'am. On table if I see that.
Okay, even after if you see that still it is there venous congestion, what are the other options for you?
And apply a back to.
We
Yeah,
can
return.
anastomose the.
You have returned, and after 4 days again you have placed over the defect. Even after that, returning towards this, sir, as you told, this clockwise or anti-clockwise. It's usually anti-clockwise, I think. So venous congestion is happened. So what are the other ways to reduce the venous congestion? In the theoretical purpose, I am telling you. Completion
So you
of.
don't believe in leeches, huh?
Oh,
Leech
yes.
therapy
Yes, ma'am. Yes, we can use it.
you can use?
We can use
Yes.
it.
Yeah.
Mm,
It
ma'am,
has helped. It has helped, especially in reverse sural and all. When you have the early venous congestion and all, you can do that.
Yeah,
ma'am,
one
sorry to interrupt. Can we move to the next session?
Yes,
Like questions from the PGs, questioning
other
from the other teams.
yes, I think so.
Okay.
sir,
Yes, yes, go ahead.
Ma'am, do you have any more questions?
yeah, that's what the question. Another is supercharging with the nearby vessels. Venous communication or venous anastomosis. Supercharging of the flap with the venous anastomosis to reduce
Yes,
the
ma'am.
venous.
Yes, ma'am.
Okay, that is another way of reducing the venous congestion.
Yes, ma'am.
Okay, yes. Okay, proceed. Proceed to next question.
Okay, ma'am. Now the session is like questions from other PGs from other teams. First is Team 1, Madras Medical College. Do you have any questions to ask for the team representing? PGs from Madras Medical College. Okay. Next, Team 2, PGs from Jipmer, Pondicherry.
Good evening. After surgery,
You
what
are from
are
Jipmer,
name
Pondicherry, right?
Yes, sir, Pondicherry, sir.
Yeah.
Name some 5 modalities of scar management of this wound after surgery.
Pardon?
Scar management.
Scar.
Scar management.
Any 5 things.
Excuse me, because we are giving a flap, you are asking about the donor site scar or scar. Can you please be more specific? Sorry.
After surgery, after recovery from the wound healed, after the wound healed.
So this
After
is a
the
flap.
wound healed, donor site and recipient site scar management. What are the advice you can give to the patient?
So once the sutures are removed, then we can ask for coconut oil scar massaging, compression garments, and then silicone gel sheets.
There is a hypertrophic scar, then contract tubex or scar gel, silicone gel. Those can be applied in. This is about the donor site where we have applied the SSG. I think that should cover it. Scar massage, compression garment, silicone gel. That should be that thing. Contract tubex.
Okay, thank you.
Next, Team 3, KGMC Lucknow. PGs from KGMC Lucknow.
Hello.
Have any questions?
My question is, what is MES score? What are its components and what is the maximum score?
You're talking about mangled extremity severity score.
Yes, yes.
Okay, so there are 5 components. I think about the soft tissue, bone, vascularity. No, if the score is more than 7, we should advise patients advised for amputation. Maximum score is 11, I guess. I'm not very confident. Hello?
Hello. Okay, maximum score is 16, not 11.
Okay.
And yes, more than 7 is an indication of amputation. And there are 4 criteria, 4 components. First is skeletal soft tissue injury, second vascularity, limb, and third shock, and fourth age of the patient. Thank you.
So that is fine. Okay, thank you.
Next question from Team 4, Stanley Medical College. Do you have PGs from Stanley Medical College? Do you have any questions? Can I move to Team 5, AIMS Delhi? PGs from AIMS Delhi. Are they present? Next, Team 6, Bangalore Medical College. PGs from Bangalore Medical College.
Hello.
You are from Bangalore Medical College, right?
Yeah.
Yeah.
Can you tell me the risk factors that may contribute to amputation? So what are all the risk factors?
So the absolute indication for amputation will be a severely mangled limb where the tibial nerve is injured, and we are not able to revascularize. We are not able to do a vascular repair for the limb. That will be the one absolute indication. Relative indications can be same vascular injury or a nerve injury with the bone loss, severe life-threatening injury of the patient, or the sepsis of the distal limb, peripheral vascular disease where it cannot be revascularized by the vascular.
And cold ischemia time more than 6 hours, or patient is in absolute shock.
Okay. And if there is a severe comorbidity and old age.
Sorry?
If there is a severe comorbidity and old age.
Yes.
Yeah. Those are relative indications. Yeah.
Yeah, correct. Thank you.
Team 5, AIMS New Delhi.
Rohit, few teams are not unable to unmute them. They are difficult. They are feeling difficulty to ask the questions.
No, ma'am. I'm just checking out everything. It's not an issue.
No.
Team 5, AIMS New Delhi.
Same problem. Nandini has posted.
Just Nandini has posted. I have sorted it out, ma'am. Nandini, you can unmute yourself. Still same problem.
Otherwise, all pages you put your questions in chat box.
No, ma'am. No, ma'am. Everybody can I do that? I don't know why.
They're not able to do it.
I just send a message also to unmute herself.
Okay, whoever is unable to unmute themselves, you put your question in chat box.
Okay, Team 7, CMC Vellore.
Hello.
PGs from CMC Vellore.
Hello, good evening. Hello.
Yes, good evening. Good evening.
Do we need to divide the sural nerve while doing the medial gastro?
No need. We can preserve the sural nerve.
It should be preserved.
We should preserve it.
What is the theoretical indication for dividing the nerve?
So that is one way where the muscle can be lengthened, but we have other options of the internal scoring and islanding and cutting the fascia at the origin. So it is not it's like a last resort where you can a little bit more you can lengthen.
Yes. And it also causes theoretically it might cause animation deformity. Thank you. Animation deformity. Animation deformity.
Okay, fine. Thank you. Actually, while holding the nerve, the muscle bulk is maintained. So we will prefer not to cut it. Sural nerve. Yeah. Okay, thank you.
Yeah. Theoretically. Yeah. Thank you.
Now Team 5, Nandini. You can ask your question.
Good evening, everyone. Can you name any classification you know of for soft tissue composite defects which involve bone loss or soft tissue? Classification for bone defects or composite soft tissue defects.
You are asking about Gastillo-Anderson or Boyd?
Anderson is like for any compound.
Fractures.
Yeah.
Boyd classification is that? Boyd classification?
No, but I'm asking specifically about Schwartz and Muir's classification.
I'm not aware of it.
So in that, group 1 is just the soft tissue defect. Group 2 is soft tissue and bone loss that is less than 2 centimeter. It is again A and B. Less than 3 and 3 to 8. Then 3 again has 2. 3A is bone loss greater than 8 centimeter, and 3B will be contaminated wound, and group 4 will be bone defect only.
Can you please share the name in the chat? I will see it.
Sure.
Thank you. Thank you.
Now, team 8, Saptajang. PGs from Saptajang. You can unmute yourself and ask your question. Team 8, Saptajang.
Hello. Hello.
Yes, yeah, we can hear you.
What is the Cormack-Lamberti classification of fasciocutaneous flap, and what type of is proximal pseudoflap?
It is a fasciocutaneous flap, which is director.
Type 1 is direct
cutaneous.
B is musculocutaneous. C is
fasciocutaneous. Operator. Third is subcutaneous.
Single pedicle.
Direct cutaneous is direct cutaneous type A.
Yeah, but what is Cormack-Lamberti classification? I'm asking about Cormack-Lamberti classification.
Type A is direct cutaneous. Type A is direct cutaneous. Type B is type C is septocutaneous. Type B is brand. Type B I forgot. Yeah.
Okay, Sri Krishna, you just answered the question.
So yeah, it's, according to Cormack-Lamberti, type A is multiple perforators entering at the base. Type B is single fasciocutaneous perforator, and type C is multiple perforators running along the facial septum, and it is taken along the supplying artery. And type D is myofasciocutaneous. Thank you.
Thank you.
Can I ask to the Sri Krishna? Sri Krishna, can you elaborate give the example of type A, type B, type C, and type D flaps?
Yes, sir. Example of type is Fontaine super flap.
Okay.
Type B is like a parascapular flap or medial arm flap. Type C is radial artery forearm flap, and type D is radial artery forearm flap along with the radial bone.
Okay.
Next questions from team 9, RML Hospital, New Delhi. PGs from RML Hospital, New Delhi.
Good evening. To the presenting team, can you just tell as to what is high pressure pulse lavage and what is its role in wound management at present?
It consists of intermittent bursts of high pressure irrigation to remove any slough or infective component to wash it.
Right. So what is its role? Is it to be used for wound management, or what is its role?
For closed cavities, I think, but since this is open, we will be able to do a debridement in a more less injury manner. Since
Actually, can it be? She's asking you. Can it be used for open wounds also?
Can be used. Not
Okay.
recommended.
Have you seen knee replacements done?
No, sir, I have not seen.
Okay, fine. So when they do cutting off those bone chips and components, they will do this high pressure irrigation and absorption, like the vacuum suctioning of those small chips of bones. Likewise, can you use this high pressure suctioning for wound debridement? Because you'll see sometimes the RTAs and all with a lot of foreign bodies, that mud and free particles and all those things. After one wash also, you can see the difference in the wound bed. So it is one of the good choice for along with our surgical debridement, this will act like a mechanical debridement. Yes, the repeated washes do give benefit with this sort of high pressure washes.
There is a beautiful saying. There is a beautiful saying for that. The solution of pollution is dilution.
Exactly.
Solution of pollution is dilution. So frequent wash is important.
Yeah.
Especially when there's a lot of dirt tattooing after an RTA, this will help.
Yes.
Okay, ma'am. Thank you, ma'am. And now Team 10, Gandhi Medical College. PG from Gandhi Medical College.
Hi, good evening. Team 10 Gandhi here. So apart from gastrocnemius, any other muscle flaps that can be used to cover the knee joint?
Vastus lateralis can be used.
Yes.
Actually, sartorius has been described, but since it's a very important muscle, it's usually not taken, I think. But
Yes.
also, it's also very strap-like muscle. We cannot. It's not. It's only for a very small. The defect size. It's dictated by the defect size. It's not
Okay.
suitable. Not suitable for all knee defects.
What type
Any
of
other?
what type of muscle is this sartorius
Type
in classification?
Alocular, segmental.
Type 5, sir.
No, it's type 2. Matthias and Nehai classification. And any other muscle from the leg apart from gastrocnemius that can be used to cover the knee joint? That has a constant perforator from anterior tibial artery. It belongs to lateral compartment of leg.
Peroneus brevis, are you talking about?
Longus.
Peroneus longus, yes.
We're talking about longus, not brevis.
Yes, ma'am, yes. Thank you.
Next question from Team 12, MAMC New Delhi. Do you have PGs from MAMC New Delhi?
Hello. Good evening. Hello,
Can
can
hear
you hear
you.
me?
Yeah.
Yeah. Can you please classify muscle flaps according to Matthews and Nehai?
Type 1 is single perforator. Type 2 is one dominant and multiple minor pedicles. Type 3 is two dominant pedicles. Type 4 is segmental pedicles. Type 5 is one dominant and multiple segmental pedicles.
So you give example now for type 4.
Type 4
from type 1 onwards.
Type 4 is sartorius.
So why did you tell the other person that he was telling type 2?
Sorry, sir. Got confused.
Yeah, you're competing here.
Team 13, PGs from Nizams, Hyderabad. Questions from Team 13. Do we have
Yes,
Vishal or someone? Team 13? Okay, fine. Now Team 14, Ganga Hospital, Coimbatore. PGs from Ganga Hospital, Coimbatore.
Hello, good evening. So you told that for the free flap, you could use the by the Godina approach, you could use what other donor vessels can you use to do a free flap for the knee defect?
either popliteal artery or superficial femoral artery through the adductor canal, both can be used.
The descending LCFA and the medial genicular can also be used.
Yeah, can also be used. Yeah.
Thank you.
Okay, Team 15, AIMS Bhubaneswar. PGs from AIMS
One quick
Bhubaneswar.
question, because I want to understand the knowledge of free flap here. So what is microsurgery and what is macrosurgery? What decides micro and macrosurgery?
If the vessel diameter is around less than 2 millimeter or 1 millimeter, sorry, 1 millimeter, then it is microsurgery, sir.
And what is super microsurgery then?
0.7 millimeters with.
So you check these three components: super microsurgery, microsurgery, and macrosurgery. Okay.
Okay.
Fine.
PG from AIIMS Bhubaneswar, team 15. Any questions?
Good evening. Our question is, what are the sequence of events that occur in a delayed flap?
Opening up of choke vessels, and
Sequence of
then there is a relative ischemia followed by recruitment at the level of the choke vessels and alignment of the choke vessels. That's the recruitment of the potential in the dynamic territories. Then there is and the vessel becomes axialized, that it becomes in a straight flow, so that blood flow is improved. So it opens the whatever choke vessels, which then realignment of the vessels leading to neovascularization as well over the potential territory.
My answer would be the sequence of events. Phase 1, there's an immediate initial spasm of all the vessels in the flap, which lasts for 3 hours. And then following that, there is a the pre-delay size is attained in the next 24 hours. And then from 24 hours to 72 hours, the choke vessel continue to dilate. And then till 7th day, there's thickening of the vessel wall due to cellular hyperplasia. And from the 7th day onwards, it is permanent irreversible dilatation of the choke vessels, which never return to their previous caliber.
Okay.
Thank you.
Thank you.
Exactly. That is
16,
how the
last
choke
team.
vessels will open and they retain their memory to not go back. Yeah. So, who described these choke vessels? And the angiosome concepts. Hello? Yeah. So this angiosome concepts and these choke vessels, they have always been, you need to read on angiosomes. I'm sure there is a second chapter very much in general principles, angiosomes. Yeah. There you can understand the choke vessels, importance of choke vessels.
Man shot described, I think, sir.
The first person to describe angiosomes?
Man shot, no, sir.
No, the first person to describe the angiosomes, he has described many other things in plastic surgery. He can be a short notes for you.
And Virchow, sir.
Check it
Virchow.
out.
We will check it out. Thank you.
Yeah.
Is another question in a delay. What is the reason behind all the changes in a delay? What is the sequence of events which are occurred? The reason behind these events? What is the cause for these events?
We are removing the blood supply all around, ma'am. So the flap, whichever has been delayed, is only through this axial vessel alone. So this has to supply the entire territory because we have islanded it all around.
Only blood supply. Is there any nervous system play a role?
Now, and sympathetic.
You have to read about this delay. Yes, definition of the delay on the sequences of events and everything you have to read. This is a very essential part of the plastic surgery, no?
And last team, team 16, AIIMS Rishikesh. PG is from AIIMS Rishikesh. Do we have PGs from AIIMS Rishikesh? Okay, fine. Sir, can we move to the next session, sir? Spotters and
Yes.
Sir, excuse me, sir. Excuse me, sir.
Yeah, tell.
Yes, sir. Ma'am asked about the types of delay. One is the standard and next is the strategic delay. Standard we roughly elevated, while in strategic delay, only the specific vessel alone is ligated to create the effect of the delay.
The madam is asking about the chemical changes, and which changes, chemical changes in the surrounding lead to the vasodilatation and capturing the opening of the choke vessels and all that. So you have to read about the sequences of chemical changes after delay.
Okay.
the first spotter, sir, 10 minutes. We have 10 minutes to discuss.
What is the diagnosis of
Noduloproliferative lesion located in the right cheek, nasolabial fold.
Probably basal cell carcinoma.
How would you diagnose how would you get the diagnosis?
So it's Ongren's line. So above that, most commonly BCC.
How do you confirm the diagnosis?
Confirm biopsy.
What kind of biopsy?
Edge biopsy we will do, ma'am.
Which edge? What do you mean by biopsy? How will you take it?
We can take 4-quadrant biopsy, ma'am. But here any one of the edge can be taken, ma'am. If in doubt, we can take. But here, since the clinical diagnosis also suggests and the area is also more towards BCC, we can take edge.
Wide localization.
Treatment.
Okay, so the diagnosis comes as BCC, nodular BCC. So what is your next? What are your next steps?
We will do a wide local excision.
What do you mean by wide local excision?
Here in the
BCC. Yeah.
here, since it has many sensitive areas, here if frozen section is available, then we have to send a biopsy, and then 0.5 centimeter of clearance is sufficient for excision, ma'am.
0.5 is enough for all kinds of BCC?
But since it is very close to the middle cancers as well, so
Okay, there is still what about a centimeter left?
yes, ma'am. Roughly it will be a centimeter from the middle cancers. So more than that could distort the anatomical landmarks. So 0.5 centimeter clearance with if frozen section is available to ensure the edge, we can proceed.
Ma'am wants to know what are the different types of BCC. And for all BCC, 0.5 centimeter you want to give. That's what ma'am wants to know. So name different types of BCC and then you give input based on your.
There is nodular BCC and ulcerative.
No, see, there are low risk and there are high risk BCC, right? So what is the
Histopathologically
margin for a
different.
low risk and how much you need to excise for a high risk? So which types are low risk BCC? What are the types of a high risk BCC? That's what I want to know.
It is infiltrative type. So it's in a biopsy like infiltrative type, and then it's a high risk. Whether it is, but in nodular type, it is low risk, ma'am.
How many types? Already made a most, na? How many types?
Nodular, infiltrative,
Yeah.
micronodular.
Is there any word like field fire type?
Pardon, ma'am, can't hear you.
Field fire. Have you heard that word?
Field fire, yes, ma'am.
Yeah, field fire. It's a goes on scoring followed by healing and zone of ulceration and then fresh growth of BCC. Field fire type. Field fire type.
Okay.
Not your ulcerative. This is a field fire type and also infiltrative and then
Pigmented. You can also classify this based on clinical and pathological variety. Clinical is what you can see. So those will be this, like you said, this is nodular. Either superficial spreading, sclerosing, you have pigmented, and you have the CL5, like what madam is saying. So this is okay. It's a low. It has come out as a low grade BCC. So you're taking maximum of 5 mm. So if it's a high grade, you need to take until 1 centimeter, almost
1
10.
centimeter.
Yeah, this is you've excised it 5 millimeters. You've sent it for frozen section, and all the margins are free of tumor. So what is your next plan? What is your plan for?
Tell us about the defect. What is the defect going to come?
So it will be involving the inferior orbital, the nasolabial fold, and the cheek superior aspect. So if you cover your mustard advancement flap, will cover the defect. But you can also have an option of mustard.
No, part of the nose lateral wall will also go, right?
Lateral wall of the nose also going.
Yeah. So
nasolabial flap.
quickly give 3 flaps to cover this.
Forehead flap, vertically based forehead flap. Mustard cheek rotation, Limburg flap.
In Limburg flap, what will be the RSTL here? How it's going to fit in? Which line it's going to fit in?
It's too big for a Limburg flap, right?
Yes, ma'am.
Yeah. So you
It's too
said
big for a
mustard.
Limburg flap. So
Can you
Limburg is not an option.
Yeah. So what mustard A, if you want to do mustard A, how much dissection you will do? Where you will go? You think the reach will be there to end this up to the lateral wall of the nose? So what is the first choice you said? What is your first choice now?
Forehead flap.
Okay. Then?
Okay,
Then?
describe the forehead flap then.
It is based on supratrochlear artery in the paramedian region. And again, planning in reverse has to be done based on the defect size. And then once it is done, flap is marked on the forehead on the vertical axis. And then flap is elevated. And then flap can be rotated here in
One second. When you're
On
elevating the flap, what are the from the incision to where you're going to elevate? What are the steps?
Initially, it will be
initially it will be suprafacial, ma'am. And then in the middle, we have to include the fascia, and near the supraorbital region, we have to take a strip of periosteum as well, because the vessel is very close to the supraorbital region. And then we have to rotate the flap, ma'am.
We are busy on which side?
Right?
Yes, ma'am.
Basing on which side of the supratrochlear?
Right side, sir.
Ipsilateral or contralateral, sir?
Ipsilateral.
So time is can we
You don't you think there will be kinking? Or
You just think over it. Ipsilateral base, it will go. What will happen to ipsilateral base?
Yes, sir. The contralateral. Sorry, sir. Contralateral will be better, sir.
Okay, sir. Can we move to the next session, sir? Next part. 10 minutes is
Okay.
over.
Okay. Tell us about the findings.
Dendroalbuginous cyst of left mandible.
Okay. Which type of images are this?
Sir, below we are seeing the CT images, sir.
Okay.
Above first is the 3D reconstruction.
Right. So what is your diagnosis? Tell us, read about this. How will you read this?
It is a 3D reconstruction of CT showing the lower, showing the mandibular region with left side a cystic lesion present from the from the symphysis till the ramus of the mandible with infected tooth and the alveolar region.
Lytic lesion
And with the lytic lesion, yes.
ramus of the mandible. This is the cystic lesion present near the symphysis region below the parasymphysis, sorry, here the below the canine and premolar.
Almost touching the midline, almost touching the midline.
Almost touching the midline, yes.
Yeah. So what is the diagnosis?
Endoalveolar cyst.
Dentigenous cyst, sir.
Osteolytic lesion, multiple bubble type of lesion. In the fourth down, there are two bubbles.
Adamantinoma.
What is that?
Adamantinoma.
Ameloblastoma or edimentinoma. Okay. So, which are the type and
don't know the types of
what is the behavior of ameloblastoma?
Are you audible?
Yes, ma'am.
Yes, ma'am.
So differences between a ameloblastoma or and a dentigerous cyst.
So dentigerous cyst usually formed in an unerupted tooth, which is inside and forms a cystic lesion. Here, adamantinoma.
Unerupted teeth is in there?
No,
there
here it is not there.
Yes.
Yeah.
Here in the second image, it looks erupted only, ma'am. But third image, it looks a little doubtful. You're very confused. Actually, sorry.
Okay. What about this adamantinoma difference?
It's a soap bubble appearance.
Right.
The patient also have a loosening of teeth, all, and they have pain, severe pain, present with pain actually. Not able to recall any more points.
So usually unilocular. It's a dentigerous cyst. It's a multiple septate lesions with the missing teeth and also loss of roots of the teeth are also there. Some. Okay, what's your diagnosis?
Adamantinoma, ameloblastoma.
Okay, we will go with the ameloblastoma. How will you treat it?
Segmental mandibulectomy. I mean hemimandibulectomy in this case, sir.
What is the type of tumor it is pathologically?
Sir, it is a benign tumor. It doesn't locally.
It is locally malignant tumor.
Low grade malignant.
Low grade locally malignant tumor. Right.
Yes, sir.
So how will you manage it?
In this case, we'll go for a hemimandibulectomy.
Pardon?
Hemimandibulectomy. Extended hemimandibulectomy for this case, sir.
You will go for the hemimandibulectomy. So you will remove the condyle and everything.
No, sir.
What is hemimandibulectomy? What do you mean by hemimandibulectomy?
Because since it is reaching up to the subcondylar region, we thought, sir, or we can remove till the subcondylar region, preserving the TMJ condyles and the TMJ. and do a segmental mandiblectomy as well, sir. But since this image is not clear whether the condyles are involved, we aren't sure, sir. But in this first image, in the 3D reconstruction, it looks as if the lesion is very well extended into the subcondylar and might have reached the condyle, so we are not sure, sir.
Condylar. Very good. Till the wisdom teeth, up to the third molar, it is extending the lytic lesion. So from there to the symphysis,
So segmental mandiblectomy can be done, sir.
Okay. Now we are preserving the part of the condyle and you are going to the one tooth, to the normal side, right?
Yes, sir.
So
Yes,
how
sir.
will you manage it? Now you excise the tumor. How will you manage it?
Free fibula flap can be given, sir.
Tell us the planning.
So we can use either ipsilateral or contralateral side, sir. But since it is on the left side, since we can use a two-team approach, we can use on the right side free fibula. We can do, sir. We can mark on the right side fibula, marking the head as well as the lateral malleolus, leaving the top 6 and the bottom 6 centimeters. Top 6 for preserving the common peroneal nerve and lower 6 for the ankle stability. And then incision can be made near the anterolateral segment. First anterior incision can be made, and then dissection done suprafacially. And then once the lateral intramuscular septum is seen, and once we have the perforators, we can go in and then
reach the anterior compartment.
Raise the anterior compartment. Anterior compartment.
Given all facilities to you, how will you plan this case?
If all
Given
facilities are,
all facilities,
then 3D reconstruction of the mandible also can be done, sir.
What is that known as?
3D printing with
it is CAD/CAM technology.
CAD/CAM,
right?
yes, sir. CAD/CAM, yes, sir. CAD/CAM.
Okay. So tell us about that. What is CAD/CAM technology, and why do you want to use in this case?
Because it is a locally malignant tumor and it is involving only the bone. It will be a better fit for the patient and for future dentiness and everything. It will be much better when compared to our free fibula.
Very good, because there is no radiation in that case, right?
No
locally
radiation.
malignant. So you can
Locally
plan
malignant.
everything. So what is that known as? Everything planning, in a single go.
Yes, sir.
It is known as joy in a day, right?
Yes.
What is joy in a day?
So we prepare a pre-osteo integrative dental implant is also made ready along with the 3D model. So we use that to remove a fibula, make a back table dissection, and once we fit it, and once anastomosis is given, once it is viable, we also integrate the dental implants also on the same sitting itself, sir, so that patient does not come for a second procedures.
So for that, what do you need, for that planning?
Like CAD/CAM and
so we need to make sure that we need to mark the perforators before we have to streak it and mark it so that when the implant we are placing should not injure the perforators to the fibula.
Okay. Madam, any question, sir? Kamal, sir?
What are the differential diagnoses of this adamantinoma?
There's a dentigerous cyst, which ma'am told.
No. Fibrous dysplasia. Osteofibrous dysplasia is one of the main differential diagnoses.
Yes,
for
ma'am.
an
Ma'am, we'll move to the next.
Yeah, fine, no problem. Yeah, so we were talking about osseointegrated implants now. So these are also implants. Can you just tell me quickly, osseointegrated implant sequence, how long that integration will happen, and when the second stage of implants can be placed? Quickly.
Sir, first initially the The socket alone is prepared and placed, sir, in the join-a-day procedure. But most of that, if we are planning for a delayed procedure, after a period of 3 months, we take up for a socket planning. In that case, the same teeth can be measured. But if it's in a join-a-day phenomenon, then again teeth are measured separately, and after 3 months they are placed. I think so. I'm not
Okay,
sure.
now sir was telling they're going to do mandibulectomy, hemimandibulectomy there. Okay, so
Yes,
the
sir.
the minimum you're going to lose 7 to 8 teeth. Yeah. So
Yes,
do
sir.
the numbering. So what you were saying, it is 4, 1, 4, 2, 4, 3, 4, 5, 4, 6, 4, 7, 4, 8, and also 3, 1. You're going to lose that
Yes,
many
sir.
teeth. These are numbering teeth. Okay. So
Yes, sir.
now you want to put osseointegrated implants. How many screws you're going to put? A patient says, I cannot afford. So what you'll do? But I want to give an osseointegrated implant. Quick, because we have to talk about these instruments also.
Don't know, sir. Sorry.
Yeah. So you would like to take help of other specialty?
Yes, sir.
OMFS.
OMFS.
Why OMFS? Who is the best person to give the teeth alignments and about the teeth part? Have you heard prosthodontists
Yes, sir.
and orthodontists?
Yes, sir.
Because the calibration machines, what they will have is different than other specialists there. So they will give you how many screws to be placed with minimal screw, maximum teeth availability. Okay. So then they will give you a plan to give number of screws, which will go in occlusion with the other teeth. Okay. So minimal
Okay.
screws, maximum benefit. So you don't have to put 8 screws to get the 8 teeth there. Okay.
Okay.
You can just put 2 or 3 and you can complete dentures, you can place it. Okay. So osseointegration there are newer titanium screws which can integrate faster, and the duration of the procedure can also, duration of the placement of the implants can also be reduced. Okay. Fine.
Okay, sir.
Next.
Tell us about these instruments. These
Here,
instruments.
below what is the infraorbital?
First is the titanium mini plates and screws
Okay.
used for facial bone fractures. And on the right side, we have 3 screwdrivers, self-retaining screwdrivers.
Very good.
For fixing the screws initially, so that we can place the titanium screws on it and place it. And then after removing, we have to use another screwdriver to tighten the screws.
Why there are
So
color coding? You know the color coding?
for the various sizes, sir.
Okay.
The various heads, we have various sizes. So each color depicts different sizes, like 7 millimeter, 1.2, 1.7. Based on various sizes, we have various colors.
We have three type of screws. Which are the 3 commonly used type of screws? Well, according to this screwdriver.
Blue color is most commonly used.
1 mm.
1 mm, 1.5
and 2.
2.
Right.
Yes,
So tell me, 1 mm is used in which fractures? 2 mm is 1.5 is used in which fractures, and 2 mm in which fractures?
2 mm is used for mandibular fractures.
1 mm for the infraorbital, supraorbital region, and 1.5 for the nasal and zygoma
maxillary region.
Okay, very good. Which are the different type of plates you know?
Sir, you're talking about the
Type of plates.
Stainless steel and titanium alloy.
That is according to the content, according to the material. What is according to the different action of that plate?
Compression plate.
Okay.
Self-locking.
Static plate and
dynamic
plate. Okay, very good.
Any other
What is this?
any other type?
Self-compression head for the headless screws.
No, for pediatric group. Growing bones.
Recon plates.
Pediatric patients.
Growing bones. The static plates will hold the bones, right?
Yes, sir.
Dynamics also might.
Yes.
Biodegradability will not be there.
Yes, sir.
So
biodegradable plates.
Absorbable
yes.
plates.
Absorbable plates. Yes, sir.
Yes. But if you have not used a biodegradable plate in a child of say 7 years, so what would you want to do?
So we have used normal stainless steel or titanium plates. Then ideally we would like to remove the implant once the ossification has done. So probably 6 months or 1 year later, we'll call the child again and do an implant removal.
Right.
Okay. A quick question. What is the maximum indication of biodegradable plates in any case for pediatric case? Any specific case you're getting in mind? Any clinical scenarios where you selectively, no trauma, you will be using plates in such patients?
For hemifacial microsomia, all those patients where we do procedures.
Craniosynostosis?
Craniosynostosis.
Fine. Next.
Tell about this mesh. What is this mesh?
Infraorbital mesh.
Okay,
Used for orbital floor fractures. If the orbital floor is completely gone, this can be used to reinforce the orbital floor.
Okay, right. Manjula madam, Dr. Manjula madam.
Yes, sir.
Any question?
It's all right, sir. So proceed, sir.
Classify NOE fractures. Still the 10 minutes is not there, it seems. Classify NOE fractures.
Okay, so I'm going to move because we have only 1 minute left. So we
Yeah,
have
sure.
more discussion in the next part.
Awesome.
Patient, a child with a bilateral cleft lip, complete cleft lip.
Okay. Next, myself. So what are the goals of the bilateral cleft lip repair?
So, cosmetically, we have to give a proper closure. The muscles, orbicularis oris muscles should be come together, and the
So
white
here
line
the
should.
components. First of all, you have to read the components, then think about these goals. So what are the components you have to align? Yeah, you are telling. Continue.
So first, we have to identify what is the defect actually, what is the true defect. So whether it's only complete or incomplete cleft lip, or it is palate also. And then muscle, mucosa, all has to be reconstructed, including the nasal floor. So to gain the complete continuity. Then nasal reconstruction also, including the columella, alar base, nasal sill, and the filtral column. Everything has to be taken into account, so that when the complete reconstruction happens, it is both functional and also aesthetic as well.
Okay. So what are the principles otherwise? So what are the things you have to achieve by doing all these things? You are telling that goes on, telling is all the things, na? So principles.
To give a proper oral seal, ma'am.
Yeah.
And nasal communication should be closed, and also the oral competence that water seal they should.
Lip seal. Yes.
Lip seal should be given.
Yeah. Yes. Okay. And we have to address the things. What are the things you have to address?
Main is the muscle, ma'am. Orbicularis oris muscle, which is getting distracted. So we have to release it from the origin, and then give a and then the insertion also should be once we are doing the surgical procedure, it has to be released, and both has to be sutured together. So that is the main funda, not the skin alone. So the muscle forms the mucosa, muscle, and the skin all should be closed in layers and has to be approximated properly. So since the reach will not be there, the bulk is seen on the lateral side, so that has to be released completely.
Release of all the abnormal attachments of the orbicularis on both the sides, reorientation of these muscles into the normal direction, and adjust into the each filtral column. And we have to prepare the filtral columns. We have to reconstruct the filtral column, and meanwhile we have to concentrate over the premaxilla.
Yes.
Premaxilla is there, prelabium and premaxilla is there, no?
Yes, ma'am.
Yes. So both the things we have to address and prepare a aesthetically useful, and also it's a like height of the lip, and also the Cupid's bow peak, and both the filtral columns, the base of the nose, that is, I mean, nasal sill we have to create, and construct a tripod of the nostril. So what type of procedures you know about the repair of this bilateral group 3 cleft? At first phase, what is the type of procedures you know?
Hillard's rotation advancement kiloplasty.
Lip repair. I am telling about the lip repair. What are the procedures you know about the repair of bilateral lip?
Millard's repair rotation.
Millard's. Okay. Another types? Do you prefer to use the both clefts at a single sitting, a single stage repair, or in a stage repair?
No, ma'am. We prefer to repair both at the same
single
stage.
So both the clefts we have to address at the first phase itself.
Yes, ma'am.
So to achieve the symmetry of the lip height, and also to get the symmetry of the Cupid's bow, and also the height of the columella, and everything will be better. Results are very good with the addressing at a single stage repair than the stage repair. Okay. So what are among that, the techniques what you have told is Millard's is one thing. So Millard's will be better for an unilateral rather than the bilateral. So other techniques? Straight line techniques have you heard that?
Yes, ma'am, but
bilateral straight line technique is the one which will give you both the lips will be at a single stage with the vertical height of the lips on both sides we can maintain well. Okay.
We are lucky in this case, the premaxilla is not very, forwardly jutting. If suppose the premaxilla is projecting too much, what will you advise when a child comes for the first consultation?
Sir, NAM we can advise nasoalveolar molding, or we can also ask for a lip adhesive to hold it near. Gradually, lips may stretch and come near. Term for it is
orthodontics.
Orthodontics.
Yeah, what is that?
Orthodontics.
Complete name of this procedure is pre-alveolar orthodontics. So by that, we can mold the projecting premaxilla along with the other maxillary dento alveolus.
Okay, ma'am.
Okay.
You said NAM. Sorry,
Yes,
you
ma'am.
said NAM.
Yes,
So what exactly happens in NAM? When do you have to do the NAM?
Ma'am, it is initially when the child is too young to undergo a procedure.
Within the first 3 months, when the maternal estrogen effect is there, till then only we can use all these things now.
What happens with the maternal estrogens? Why you have to
So,
do it within 3 months?
so that will help in the pliability of the bones. After that, the hormonal effect goes away, and after that, it doesn't work.
Why? What happens because of the loss of the maternal estrogens in the first 3 months? Something to do with the plasticity and the elasticity?
Yes, ma'am. The elasticity of the bones, ma'am. The estrogen effects. Sorry.
That can affect the ligament, those skin stretchability, the tissue stretchability is more like how the
You are not sure, so anyway, I will let you read it. I won't give you the answer.
Okay.
There is a reason why you have to do it in the first 3 months. After
Yes,
that, it is not going to help much.
yes, ma'am.
Okay, and I've also given you this. You only mentioned because it's because of the circulating estrogens. But why? What happens with the circulating estrogens? You need to know. Okay.
What do you see in the lower lip in this patient? Do you see anything? You're concentrating only on the upper lip. Lower lip, do you see anything?
central
Quick.
part of the lower lip is appears to be thinner. The
If you
muscle.
zoom and check, you can see some things there. What is that? Fine. Name some syndromes associated with cleft lips.
Kamal, tell them that you're seeing pics and ask them the syndrome with it. You can see pics. I think that is what he's asking about. Are you seeing lip pics?
I'm not able to make out.
Yes, ma'am.
Yeah.
You're seeing, huh?
So
Okay, if you're
syndromes-
not making out also, Kamal thinks there are pits. So what syndrome would you associate this with?
Fine.
Are lip pits
So
associated with some syndrome?
You
P10,
you
10, P10, that P10 syndrome.
No.
G.
Golden Hara, sir.
So now tell me, this
No.
patient has got premaxilla. He's with premaxilla is there, but also the bulky lateral ones. Ma'am was telling NAM, dentoalveolar molding, orthodontic treatment. What is the best period of time to operate this patient?
3 to 6 months, sir.
What is the rule of 10?
Yeah.
Quick questions, quick answers. Rule of 10.
10 weeks, 10 pounds.
Hemoglobin
10 grams.
And TC 10, less than 10.
Weight should be more than 10.
10 pounds.
10 pounds.
Total count less than 10. Okay. So all this molding and all sometimes work and sometimes it doesn't work. So what is the best way to put this back? Luckily, sir was also saying the premaxilla looks okay. There are premaxilla where if you do some pressure also, they will just get necrosed. So how would you handle this now?
Both
So,
sides.
yeah. So along with this, if you want to reduce the pressure in the premaxillary region, you will do something else to reduce the pressure somewhere else.
Back cut.
Yeah.
The volar be released. The vomer bone should be released so that it doesn't give any tension. So from the hard palate, we have to release so that.
Sorry to
exactly.
No.
You're in the time
Yeah,
limit.
you can proceed, I think.
Fine. Next. Yeah. So you can answer these questions directly by yourself. What is your diagnosis? And
Axillary breast, bilateral axillary breast. In the axilla, we can make out right side a bigger one, left side is smaller.
Yeah, that is the diagnosis.
Yes, sir.
Seriously? What is the diagnosis? Along with that, what is there?
Gigantic breast.
Yeah.
The types of
Mammary
Mammary hyperplasia classification types.
Yes. You are telling gigantic.
Don't know that.
No, are there any types reaching up to the umbilicus or below, above that?
Great.
Sir, it does not extend below the inferior mammary fold. Then that nipple ptosis extends below the inferior mammary fold. Last grade will be reaching the umbilicus, but I don't know what is the grades, sir. I think something related to this. I'm just guessing, sir.
Fine.
Okay, we are going with your first diagnosis is axillary breast, So how will you counsel this patient?
Only the axillary breast, we will go for a excision of the.
If it causes significant impairment, both cosmetic and functional for the patient, then we can ask for the surgical removal. So we can tell the patient about the surgical procedures of requiring to remove this axillary breast. And since if it is axillary breast, once it is confirmed, then there is a chance of axillary breast in the milk line as well. So we have to tell that as well to the patient.
Okay,
will
let's
you
separate. Sorry, go on. Go ahead, sir. Go ahead.
Yeah, how will you confirm it?
There'll be a nipple, sir. If it is axillary breast, then we'll have a small nipple as well.
We confirm it in the biopsy.
And biopsy also we can confirm.
You do. Which are your options? Now, third question is, what are your options for this condition?
Breast reduction you're talking about?
No. We are going with the axillary breast, your diagnosis.
Surgical.
Option for this condition? How will you treat?
Surgical removal, sir.
Okay.
Then liposuction.
Tell us the stepwise operative management.
So make a longitudinal incision, elevate the skin flap, identify the apparent flat globules, which will be different compared to the axillary fat. More of a globular flat will be present. All those are excised. They may be extending in a small accessory region. They could be extending through the pectoralis region also. So everything should be excised, and after that, skin closure. We have to keep drain, suction drain.
Won't the skin be redundant?
Removal of excess skin also should be done based on the amount of tissue.
So what will be your incision plan? What it is straight line or what? How will you do?
You said longitudinal, no? You said longitudinal incision.
Yes, elliptical incision can be.
You want to put a longitudinal incision here?
Sir, axilla. There, what's the concept? There are so many creases are there in axilla, no?
Madam is asking, Manjula madam is asking something.
Yes, sir. Along the crease line. Transfers.
Transfers only, no?
Yes.
Transfers. And then you excise. And then maybe if it is a smaller one, you don't even have to do an excision. You can just do a liposuction also, and then give a pressure garment. The skin may, if it's on the left side, doesn't look very big. On the right side, looks like excess skin also. Is that also an option?
Yes.
So you should.
So if you want to do a liposuction, how will you proceed?
First, prepare tumescent. and then inject the amount of first we have to quantify how much amount of fat we are going to take, and that amount of tumescent has to be injected, and then it has to be
make a small nick.
Make a small nick, and then we have to
suction cannula.
Using the suction cannula, we have to aspirate, maintaining the continuous negative pressure.
How will you make the tumescent solution?
The RL with the lignocaine.
With 30 ml of lignocaine. And in this, if this is specific to this case, then we don't add sodium bicarb or adrenaline. Adrenaline we have to add, adrenaline we have to add, but we don't add sodium bicarb for this patient, for this liposuction.
Sodium bicarbonate, and what else won't you add?
Hyaluronic acid can be added.
You will add higher
No, not for the sodium bicarb and hyaluronic acid won't be added for this patient, but for routine other purposes we add.
Would you add a steroid in your tumescent fluid?
No.
We have not added.
No, not for this. If you're doing a liposuction of the abdomen and all that, would you use a steroid?
No, ma'am.
Not added, ma'am.
You've not. Okay.
And you will exercise the skin, as Madam has said, there is redundancy of skin, right?
Yes, sir.
Yes.
And what is your post-operative care and follow-up?
We have to maintain a negative suction pressure to rule out any prevent the formation of any seroma. Compression
compression dressings should be given post-op, sir.
Okay, how long?
Sir, we have to keep the suction till the drain is less than 10 ml, at least for 48 hours. Compression dressing we keep for at least 5 days at least.
5? Compression garment?
Compression garment, we advise them to have it for
3 to 6 months.
But our dressing,
the problem at the axilla is the lymphoria. Okay.
Yes,
most of the lymph glands will be there. There is a lymphoria will be there following the manipulation of that axillary breast. So we have to put the negative pressure drainage, and it will be there for 2 to 3 days sometimes. And most of the times, this axillary breast also contains a fibrofatty tissue, that is a breast glandular tissue. So we need to have, instead of this liposuction, we have to excise the gland also. Okay. Followed by put one drain, and after 3 days, what you have told, this 10 cc, less than 10 cc, we remove the drain. And this pressure garment is not necessary. So just like routine dressing will be enough.
Okay.
Yes. Okay.
Sir, can we move to the last part of our
yes.
today's?
Post-burn scar contracts document.
So all burns are MLC cases, sir. So first, if the patient is come in an acute stage, MLC is mandated. But since the patient has come as a post-burn neck contracture, MLC is not needed, sir. Then other things to be documented are what all the mode of injury, then where was the treatment obtained initially, and what was the what are the procedures which was done, and are there any other associated injuries, and where was the treatment done, and whether the patient was going for regular follow-up or not, and physiotherapy, compression garments, neck collar, the usage of all these things, and then comorbid conditions. All these things have to be documented, and then the amount of contracture also should be documented, since it is lower lip is reverted, and then if the patient is able to eat and maintain proper lip seal without any dribbling of saliva or spillage of food and liquids, all these things to be documented, sir.
would you like to document about the white patches also?
Yes, sir.
Yes.
Hypopigmented scar.
Hypopigmented. Okay, yeah, you said that. Okay.
And the use of any compression garments.
Yeah.
What is the difference between the pediatric neck burn contracture and the adult neck contracture, burn contracture?
Pediatric neck contracture may cause bone alignment to change. The bone growth deformity can change that. We need to address that also. In adult, since the growth has been completed, we may need only to release the lip to give the lip seat to that. But in a pediatric child, the constant pressure contracture can cause deformity in the mandibular growth also.
Okay, so you have already mentioned, but in specific word, I want to ask you. So the question is, how will you document all the aspects related to this injury? So what is the one word you will use saying that these will be the issues in future? What is that word?
Class 4 mentosternal. Oh,
no, technical language. This is a documentation where you have to write something to the lawyer to understand because they are fighting the case now.
Grievous injury.
No, you have to write functional issues.
Okay,
Yeah.
sir.
So functional issue, there is a grading book where they will mention these are the functions which are having issue. So according to that grading, you will be giving the percentage of disability to this person. Okay. So they will ask you correctable disability, non-correctable disability. So you have to answer that also. So in this question, in this, that is how you have to write functional disability, which is correctable or not correctable. Okay.
Okay, sir.
Yeah. So that's the important words you have to mention. So in this patient, what are the functional disability?
So lip is everted, so she will definitely have a difficulty in swallowing, chewing, and also drooling of saliva. She may have, and this neck
Patient
is
is not able to extend the leg and extend the neck and bring it to a neutral position. So even the gaze, she has to look in upward gaze for even neutral vision. So that is there, sir.
Yeah.
Probably the
So
lateral section of the neck also may be compromised.
Okay. So what is the grade now? And what is the immediate, what is the anesthesia complications or anesthetist? How would they be able to help in this patient getting on the table for you to operate?
So first we have to take an X-ray to look for trachea and the patents of it. And then for anesthetic workup, we have to inform the anesthetist prior as well. And they have to, if it is available, they have to bring in the fiber optic endoscope for intubation as well. And I will also.
What is that intubation known as?
Wide awake intubation. Awake intubation. Patient.
Yes, awake intubation.
Anesthesia.
Awake.
Yes. Okay. He fails now. What is your thing? How would you do?
So then we have to surgically release, giving local under tumescent or under local anesthesia, minimal surgical release so that patient is able to release the
you will release or you want to give one position to the patient and then try attempt to release. What is the
shoulder
position?
rose position so that the neck is extend minimal whatever sandbags under the shoulder.
There should be someone holding should be ready to support the head also. The gradual release is given, gradual extension is done.
Well, can I have a question?
Sir, yes, sir.
Yeah. So you have told nicely. Only I have to ask if the patient is having a acid burn, what is the legal and financial implications? So what is the legal and financial provision given by our authorities concerned? Suppose you have an acid burn, not an thermal burn.
Acid burn victims are entitled to compensation under a particular act. I think they are financially government supports them for their occupational rehabilitation.
So what is the financial limits?
Sir, I am not aware of the amount that is given, sir, money that is given, but they are eligible to receive a compensation. I am aware of that.
Yeah, so Lakshmi versus Union of India, a case filed by Ganga Hospital, The Supreme Court directs for about amount of 10 lakhs for all the rehabilitations and treatment of the patients of acid burns. So the legal documentation of the acid burn cases are very important, and you have to document by serially right from the beginning. When accurately, it is also the collector is entitled to give 25 lakhs, 25,000 to start with. The rest amount can be also dispersed.
Okay,
So
sir.
I think as a plastic surgeon, you may be called for an expert opinion regarding the case of its detailed treatment. So you must know this implication as far as the patient's documentation of acid burn are concerned.
Okay, sir.
It comes under Criminal Code Procedure 54C. So they
Yes.
will be entitled for a lot of privileges from the government.
Sorry,
Okay.
madam's name is there. Lakshmi versus Union of India case was there in Supreme
Yes, sir.
Court.
Yes, sir. Yes, sir.
Thank you.
Thank you.
Okay, can we proceed?
I think we are at the end of the total sessions for today.
Okay.
Final panelist remarks, sir, regarding the presentation of the PGs and any more suggestions to the presentation or anything by each panelist. First, Madam, Smita Madam.
Yeah, well done, both of you.
Thank you.
I would only have one suggestion that when you're in the exams, when you're answering, don't lead the examiner to an area where you are not very confident of your answers. You should know how to lead them to an area where you are very confident and they'll ask you questions on that only. So that is one of the ways that, like, you can win over in the exam. But otherwise, you've done well. Good, and congratulations.
Thank you.
Ma'am, next, Kamal Kumar, sir. Oh,
Seniors should go first.
Yogesh Bhatt, sir.
Dr. Yogesh Bhatt, yeah.
Pardon, you are in which year, both presenters?
Finally, sir.
Final years. Oh, excellent. Your thought processes are very nice. It seems you read a lot of topics and you're prepared for your examination. And your answers were very right. Very nicely answered all questions. So God bless and keep it up. I think you will be really shining in your final examination. I would like to thank the organizer of Plastiquest because this is a great platform. I would say the exposure for a younger plastic surgeon, especially the registrar, in front of all senior plastic surgeons of throughout the India, is one of the great experience for them. And I think they are really, really getting ready for their final examination. So thank you very much, Plastiquest team, and keep it up. Thank you so much.
Thank you. Thank you.
Thank you.
No, it's ma'am.
Okay, congratulations, both Sai Karthik and Prakash presented
Thank
very
you.
nicely. Okay, when are you going to attend the exams?
February,
not yet
possibly, not yet.
officially is told, ma'am, but probably March.
February and March, but not officially told it.
Okay, so next year, 2025,
Yes, ma'am.
March. Okay. You have to read the basics first.
Yes, ma'am.
And then all the surgical anatomy. We are all the surgeons related to body, top to hair to toe. No? So
Yes, ma'am.
surgical anatomy as well as functional anatomy and surface anatomy, everything we must know. In that, the basics by embryology for the clefts and craniofacial, we have to read about. And just basics for all the concepts and the basics you have to read. That's what I remember. I wanted to tell you. And anyhow, all the best for you to attend the exam. And thank you, organizers and all my seniors and my friends. Thank you very much.
Thank you so much, ma'am.
Thank you.
Yes, thank you.
Yeah.
Kamal, sir.
Yeah. Good luck to you both. You did well.
Thank you, sir.
Yes, you still have 6 more months to read more. So you read concept wise, you understand the subject. you just make small post-its and keep it in the grab and smith. So that last month, you can just go brush it up fast and finish it off. And discussion, always you discuss with your juniors. Whatever you read, go and speak to them. And you take lectures for your juniors. And keep attending all these classes. Plastiquest and any bi-monthly meets in Chennai are very common. So keep attending all those classes and take everybody's view and understand the concepts of plastic surgery. It is going to make a lot of difference. Yeah. Good luck to you both. And thanks, Lakshmi ma'am, for pushing me always. And I'm looking forward to be there always. Thank you very much. Thank you, everybody.
Thank you so much, sir.
Thank you, Team Plastiquest.
Thank you very much.
Thanks,
I
Smita
invite
ma'am.
our patron,
Raman.
Dr. Bhattacharya sir, to
For the final comments.
final comments.
Well, I highly appreciate today's proceedings. Without being biased, I have noted certain points from my own experience. The candidate said Pontin described superflap in 1991. Actually, it is 1981. So just check it. And regarding the need effect, what I appreciated is always try to select the simpler and effective method. Okay. Think that the patient belongs to your family. Then you will restrict your thinking to unnecessary complicated procedures. For example, you said sural neurocutaneous, very well knowing that it has its own morbidity of the sensory loss on the dorsolateral aspect of foot, plus adipofacial flap, for example, the pedicle. Now, not much of adipose tissue is there, remember it. And you have to leave behind 2 to 3 globules of fat when you are undermining the skin for adipofacial flap to protect the dermal subdermal plexus. If you don't do that, your flap may survive, but there may be wound dehiscence at the undermined area. Second thing is tunneling is not always easy, that adipofacial, because you have a small bridge of tissue. So you have to keep that in mind. Now, when you talk of gastrocnemius, always think that in an already traumatized limb, why should you sacrifice a functional unit? If possible, don't sacrifice a functional. So that is basic thing, you know. And then regarding the titanium plate and screws, the mesh, which was a, there was a figure of mesh. Of course, you have to diagnose that, you have to identify that as mesh and where it is used. But in practical use, autogenous tissue is always preferred over mesh or screws or whatever it is. Because you have the conchal cartilage, which aligns nicely with the infraorbital margin. And once you have reduced it or whatever you have identified, if you put a conchal cartilage, which is so easy to get, that really aligns the floor of the orbit. Because sometimes the mesh may cause problem, and it's a very critical area that is high. So that is another point. Then in bilateral cleft lip, Madam suggested straight line suture, which is originally described by Manchester. It's Manchester's repair. Then further modifications were there. But always, as in this case also, there is a hypoplastic prolabium. So in most of the cases, it is hypoplastic. And therefore, you have to add tissue to the mucosal aspect also. Even if you unfold the prolabium, even then there will be deficiency. So to cover that, B effect, you use bilateral mucosal flap from the lateral segments and just superimpose over each other. That takes care of the height of the prolabium in the central part of the limb. So it is Manchester repair and its modification. And regarding the axillary breast, you look at it as a natural tissue expander. And therefore, you have the liberty to plan your incision, if not liposuction, in such a way that it is not vertical. Once you have excised it, it's an expanded tissue. You have excess of skin. Rather, after planning the flap, you might have to trim the extra skin. So always think in such cases, whether it is a lipoma or is axillary breast or any such situation, then it is a natural expander. So nature is having a disease or problem, but it is helping you also. So take the hint from the nature. And lastly, about documentation of the PBC neck case, you should document whether the patient is epileptic or not. Very, very important, because when they get the attack and they fall over the oven or whatever it is, then they get epilepsy. Any facial burn, you must ask for or document for epilepsy. And the other thing to be documented is the intrinsic and extrinsic segment of the contracture. I hope you understand what is the importance of it. The intrinsic contracture is the contracture within the scar. And the extrinsic contracture is the effect of contracture to the adjacent tissue, as it was very evident in these cases. The nasolabial fold, the eyelid, everything was pulled towards the chin. So the importance is that once you release or completely excise the scar and complete release, one of the indication of complete release is automatic correction of the extrinsic effect. So they will go back to their normal place. So therefore, it is very important to document the intrinsic and extrinsic effect of the contracture. Otherwise, you all have done, both of you have done well, and I appreciate the way it has been conducted, and being a part of this Plastiquest. I see the interest amongst the residents in the whole country.